Good afternoon, everyone. Thank you so much for joining our Debbie's Dream Foundation webinar series. Today's webinar is featuring Dr. Michael Choti, who will give us a presentation on surgical updates for the gastric cancer patient. I'm Brittany Starks, Communications Director for Debbie's Dream Foundation, and I will be moderating today's webinar. Next slide, please. We would like to thank our webinar sponsors, Platinum sponsors Amgen, Daiichi Sankyo, and Merck. Silver sponsors Bristol Myers Squibb. Bronze sponsor Seagen. Next slide, please. First, I will share information about stomach cancer and Debbie's Dream Foundation. Then we will hear a presentation on surgical updates for the gastric cancer patient with Dr. Michael Choti. The presentation will then be followed by a Q&A session. Next slide, please. You can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions at the conclusion of the presentation as time allows. Next slide, please. This year, nearly 30,000 Americans will be diagnosed with stomach cancer. Stomach cancer is the second leading cause of cancer deaths worldwide after lung cancer, with a dismal 5-year survival rate between 20% and 30%, depending on the country. Many patients are asymptomatic during the early stages of stomach cancer, leading to late diagnosis. Next slide, please. Debbie's Dream Foundation is dedicated to raising awareness, advancing funding for stomach cancer research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more by visiting our website at www.debbiesdream.org. Next slide, please. Pictured here is Debbie Zellman, the founder of Debbie's Dream Foundation. Debbie was diagnosed with stage 4 stomach cancer in April 2008. She had no risk factors and only vague symptoms. At the time, she was told that her chance of being alive in 5 years was only 4%. Debbie founded DDF in April of 2009 and dedicated herself to helping others with stomach cancer by raising awareness and providing resources and education. Simultaneously, she endured harsh chemo regimens and targeted treatments and experienced many reoccurrences. Unfortunately, Debbie passed away on December 23, 2017, at the age of 50, after a 9.5-year battle with cancer. As an organization, DDF continues her important work and legacy. Next slide, please. In a few short years, DDF has achieved many great milestones. We have 32 chapters across the US, including Canada and Germany. Our PrEP program helps patients, their families, and caregivers match with survivors and caregiver mentors using disease-specific criteria, including stage, biomarker, and location. We host educational webinars and symposia year-round, and our website contains in-depth information about stomach cancer. We also have provided $1.4 million in research grants to date. Next slide, please. Each year, patient advocates come together at our annual Debbie's Dream Advocacy Day with the ultimate goal of securing funding for the Department of Defense's peer-reviewed cancer research program. This program allocates funds for stomach cancer research. This year, we hosted a virtual advocacy day with more than 130 registrants. Join us next March for our 11th annual advocacy day. Next slide, please. Here you can see some of our upcoming events in July and August. And to learn more, you can visit our website and check out our upcoming events tab for the latest happenings. Next slide, please. DDF is headquartered in Fort Lauderdale, Florida. Our hours of operation are Monday through Friday from 8:30 a.m. to 5 p.m. Eastern Standard Time. Also on this slide are important phone numbers and email addresses you can use to contact our office and staff. Next slide, please. We will now begin the presentation on surgical updates for the gastric cancer patient with Dr. Michael A. Choti. Dr. Michael Choti is a surgical oncologist and chief of surgery at Banner MD Anderson Cancer Center at Banner Gateway Medical Center. He received his medical degree from Yale School of Medicine, completed his residency at the University of Pennsylvania, surgical oncology fellowship at Memorial Sloan Kettering Cancer Center, and has been practicing for more than 25 years. He served on various leadership positions in national and international societies, including NCCN. He is a founding member of our Scientific and Medical Advisory Board. Dr. Choti has also been the principal or co-investigator for a variety of clinical and preclinical studies examining new approaches for the treatment of gastrointestinal cancer. We would like to thank Dr. Choti for taking the time out of his schedule today. And now, Dr. Choti, I will turn the presentation over to you.
Thank you, Brittany. It's a delight to be speaking to the group here and to be participating in these activities for Debbie's Dream Foundation. Here, let me just show you this next slide. This is in 2012 when I was fortunate to be the recipient of the Tree of Life Medical Award in 2012. And this is a picture with me and Debbie. And I've been involved in this foundation since the beginning, and I'm really delighted to see how it continues to thrive, even without the push of Debbie herself, she was so instrumental early on. But really to see the legacy continuing and really to focus on emphasizing what candidly is really an underserved, underappreciated and common malignancy in the U.S. and worldwide. And really, if you look at the relative NIH funding compared to the frequency and prevalence of this disease, it's an area where we need to continue with our advocacy as well as our education. We'll talk about also some of the challenges that are specific to the gastric cancer patient. So I was asked to give some surgical updates for the gastric cancer patient. As a gastric cancer surgeon, I'll focus on really the surgical management, just in general overview. I'm also going to touch on another topic which is unrelated, but really an update on what's called ctDNA or liquid biopsy, an area that's really starting to emerge in a variety of cancers, less so in gastric, but I think it's important for us to learn about it so we can continue to advocate continued trials and advancement in the gastric cancer space. So again, NCCN guidelines, these are common guidelines for the management of gastric cancer. And most of you hopefully know, and surgical therapy is really the mainstay of localized early stage gastric cancer. So you can see here, this is the recommendation. There's a workup depending on the stage of the cancer. The management varies. So early stage stomach cancer, T1, early stage, surgical surgery up front. Stage 4 disease typically is not a surgically managed disease, but we'll touch on that a little bit. But the majority fall into this local regional realm, in which case those are patients that are managed in a multidisciplinary fashion. And one important aspect about this from the staging standpoint is this laparoscopy and cytology. So patients who have intermediate stage gastric cancer, often the first step, as well as imaging and blood tests and so forth, it may entail a laparoscopic evaluation in the peritoneal cavity to determine if there's any spread, which would make it stage 4 disease, both for visualization of peritoneal disease, but also what we do is washings and to get the cytology, because even microscopic cancer cells in the peritoneal cavity is associated with basically of already spread disease. And then, of course, the management, as we know, in the patient with this local regionally who are medically fit, if it's an intermediate stage, then really the standard is for gastric cancer, as you know, it's a combination of typically of chemotherapy and surgery. Both are recommended in some combination. Historically, gastric cancer was managed with surgical removal first and then chemotherapy after. And there have been trials over decades to demonstrate the advantage, the benefit of the addition of chemotherapy in the patient who had post-operatively. It really started in GI malignancies, I would say, with rectal cancer. We started really pushing the use of chemotherapy and radiation therapy in rectal cancer prior to surgery. Neoadjuvant therapy, and that's been, and now even in rectal cancer, for example, we do even total, we call it TNT, total neoadjuvant. So the chemotherapy and chemoradiation, all of it is given up front. Surgery is done at the end. In gastric cancer, it's been lagging, if you will, in this kind of this management paradigm where it was surgery up front, and then there were studies showing that postoperative adjuvant has a benefit. Now it's pretty standard in the intermediate stage, that is not the really early stage where only surgery may be done, or the advanced stage where only chemotherapy is done. It's that intermediate stage in which now chemotherapy is typically recommended prior to surgery. And we'll talk about a little bit about that. So neoadjuvant chemotherapy. Just to touch on the role of radiation therapy for gastric cancer. Again, this is an area that's more controversial. I'm not going to spend a lot of time talking about this, but one area we'll talk about, and that is the cancers in well, to say that cancers of the esophagus, those are patients are typically maybe often treated with preoperative chemoradiation therapy, and patients with stomach cancer in the main stomach are treated with preoperative chemotherapy. So often confusing to the patients. What's even more confusing is the so-called GE junction, gastroesophageal junction, cancers that are situated right in the junction between the esophagus and the stomach. And that can be often confusing. Do we do with the preoperative chemo paradigm or the preoperative chemoradiation paradigm? And again, this is often, we can talk about that in the discussion going forward. So I mentioned the neoadjuvant chemotherapy. There have been a variety of different regimens. There was a trial that earlier on demonstrated this combination of ECF prior to surgery compared to surgery alone or chemo after. And now more recently, this regimen of docetaxel, 5-FU-leucovorin, and oxaliplatin, the so-called FLOT regimen, F-L-O-T. The data, this is the trial that's supported, published in 2017, demonstrating a significantly improved outcome compared to even ECF or certainly upfront surgery. So I would say the standard for the intermediate stage gastric cancer, node positive or full thickness in the wall, FLOT chemotherapy followed by surgery. Neoadjuvant is pretty much the standard. So what are some of the clinical questions or the outline we'll address today? Let's focus on some surgical issues as you're hearing from a surgeon. What is the optimal extent of surgical removal? What is a gastrectomy and how much of the stomach do you take out? What about the lymph nodes? We always hear about the lymphadenectomy. Is that important? We'll touch on a little bit about some of the nuances of laparoscopic versus open, and some of the problems or complications that occur after stomach surgery. And I'll spend the last 15 minutes or so on a pivot to talk about a completely different topic, not about surgical management, but about this whole thing about circulating tumor DNA. Very interesting, fascinating. I think you as the audience would be interested in learning a little bit more about it and following where this evolves in gastric cancer going forward. So basic principles of surgical therapy for the stomach, it's pretty clear. The goal is to complete removal of the cancerous part of the stomach, negative microscopic margins. If the tumor's grown into any structures, so-called a T4 cancer, then those should be removed. Removal of the regional lymphatics. Consider rare cases we put in, some cases we may put in feeding tube in malnourished patients. And in patients with incurable disease, resection are typically reserved, or advanced disease, stage 4 disease, we typically consider those incurable. And there, the goal should not be just to remove the stomach if the cancer is already spread. But in select cases, we may do surgery for palliation of either obstruction or bleeding. So what is a gastrectomy? You hear all this terminology. One is that this is, of course, the anatomy, the cartoon of the stomach, the esophagus. This is the GE junction, and this is the so-called the pylorus, the valve between the stomach and the beginning of the small intestine. This is the duodenum. So depending on the location of the cancer, how much of the stomach is removed. So cancers in the antrum, which is the distal, the downstream end of the stomach, or in the body of the stomach, so-called a subtotal or partial gastrectomy, preserving the upper part of the stomach and preserving, importantly, the valve between the esophagus and the stomach is useful. The one on the right, And in cases where the cancer is more proximal, where you need proximal clearance margins, then not uncommonly a total gastrectomy is done, where both the upper valve and the lower valve is removed. So that's the extent of resection. We tend to favor the subtotal if at all possible. The function is better, the long-term function, preservation of the gastroesophageal junction and the valve, as well as the remnant stomach, can improve long-term outcomes compared to a total gastrectomy. But but patients do well, of course, with both operations. This is a cartoon of the reconstruction. So this is called a subtotal gastrectomy. Don't worry about some of the terminology. With a Bill Roth 2 gastrojejunostomy. Well, what the heck is that? Bill Roth is a surgeon from centuries ago. This is the reconstruction of the gastrojejunostomy. Jejunum, gastro, it means connection between the stomach and the intestine. So this is a cartoon of the subtotal gastrectomy with reconnection of the small intestine, closure of the duodenum, you can see, and a reconnection side to end to side between the stomach and the small intestine, called a Bill Roth 2 gastrojejunostomy. This is a drawing of the subtotal gastrectomy with so-called a Roux-en-Y, again, unusual terminology, gastrojejunostomy, where instead of the side of the jejunum being connected to the remnant stomach, a limb, you could see a limb of intestine is brought up. The small intestine is connected to the small intestine below, and a limb of intestine is brought up like that. Why is that? This is clearly a little bit more complex in its reconstruction, but this is really the operation, I think, of choice for most subtotal gastrectomies, because the most important reason is one symptom of reflux. You can see with the jejunum, with the and I don't know if you can see you may not be able to see my pointer, but the bile juices come down into the jejunum, and so creating this limb, 60-centimeter limb, typically avoids the bile refluxing up into the esophagus. So most patients function better with this so-called Roux-en-Y reconstruction than a Bill Roth 2. So when a lot of stomach is preserved, often the Bill Roth 2 can be done. This is the reconstruction that's typically that I do and most surgeons will. Total gastrectomy, when the whole stomach is removed, of course, you can't bring up a loop there. You always have to create a limb, a so-called Roux-en-Y limb, reconnecting the esophagus to the stomach, creating this long limb before the bile juices are reconnected here. You can see, and then this little alternative reconstruction is called a little pouch or a Hunt-Lawrence pouch. Sometimes rarely we do. It doesn't really change much, and so I think this is less commonly done these days, that little variation. But basically, limb of intestine. You can see one important piece here is the main function of the stomach is the reservoir capacity of it. And you saw in the earlier sketch when the subtotal gastrectomy is done, and that little pouch of stomach can sometimes dilate over the years and almost restore that reservoir capacity. While sometimes that functionally can occur with a total gastrectomy, less common, and therefore small meals. That's why we always say eating small meals more frequently. It's because that reservoir capacity of the stomach is lost after its removal. The ability to absorb really is done in the small intestine, and so that patients say, how can I live without any stomach at all? Patients do, as many of you know, do remarkably well with no stomach at all. But it's really that loss of that reservoir capacity that is the main, often the most common long-term symptom related to it. We can talk about questions come up about other things such as dumping syndrome. This valve here kind of controls the food contents that comes down. Without that valve, there can be more of a rush of food stuffs down into the small intestine, particularly high sugars and things like that can cause dumping syndromes and other things. That's the reason. That's the anatomy, because that valve is lost, so that the digestive contents will go down more rapidly into the small intestine than would normally occur with that pylorus valve that's present. Long-term subtotal versus total, as I mentioned, we oncologically, the subtotal should be sufficient as long as that proximal or up margin is negative, that we shoot for. And so you can see the quality of life, long-term function following gastrectomy. This is one study showing that weight loss, number of meals, bowel function, overall physical function was better with the subtotal. And so that's certainly what we strive for. But still, most patients still can do well with complete removal of the stomach. I did mention earlier about this so-called GE junction. This is kind of complex. Cancers in the very proximal stomach, right at the valve between the stomach and the esophagus, are more complex to manage. First, by the way, the incidence is going up of the proximal. The distal gastric cancers the incidence is going up less. It's the so-called the cardia, which is the proximal, is going up. This is just one sketch, one graph showing that in males, white males and black males, the incidence, but in all the entire population, the proximal incidence of proximal gastric cancer is going up. So this is more difficult to manage just because of the function and the loss of that valve. And the other is candidly that if it's the management of esophageal cancer versus a stomach cancer is kind of two sides of the elephant. So we use a scoring system you may hear about, or a staging system called the CWORT classification. So based on its location. So a CWORT 1 cancer is just above that valve, and it's really an esophageal cancer. A CWORT 2 is involving at that junction, and a CWORT 3 is in the cardia of the stomach. You can imagine that, you know, cancers can start in the bottom and grow up, or in the middle and grow down. So this distinction of sometimes can be difficult between a CWORT 1, CWORT 2, and CWORT 3, and it's sometimes within centimeters of difference only, and yet the management may be very different. The reconstruction may be different, and also, as I mentioned, even the neoadjuvant therapy. Esophageal cancers, we may favor chemoradiation therapy, often the so-called the CROSS trial, if you will. Chemoradiation has been shown to be beneficial. I mentioned to you the data on neoadjuvant chemotherapy for gastric cancer. And all the studies that included both, but the esophageal cancer studies, many of them included GE junction within that, and many of the gastric cancer randomized trials included GE junction cancers within that. So it's a little bit, sometimes this is can be individualized and really dependent on the multidisciplinary team as to the management of these GE junction cancers. It can be complicated, and these are some of the nuances. Prognosis is somewhat poor, rarely it's less associated with can be associated with GERD, sometimes with Barrett's esophagus, particularly the more proximal one. And again, how the reconstruction is done, and sometimes it can be, you know, it can be done laparoscopic, robotic, different approaches. And this is just a gastro for those either distal esophageal cancers. That's a different operation. So called proximal gastrectomy with esophagogastrectomy, and then the reconstruction can be done either with a reconnection in the chest, typically is done. The stomach is brought up and reconnected in the middle of the chest. Rarely does the whole esophagus need to be removed in this situation. So we could talk about early gastric cancer. I won't spend a lot about this, but most of the cancers that are managed surgically are this intermediate, the ones that are through the wall in the lymph nodes already based on the stage. For the rare cases in which the cancer is very early, a T1 right on the surface, that even, first of all, surgery alone can be typically, or removal alone can be typically done. But even in those cases, there we don't need to remove even the lymph nodes around it. And so how the removal can be very local. And so in select cases, even endoscopic mucosal resection or endoscopic thicker resection can be done, or even some of these laparoscopic local removal can be done for early stage. And really the reason is that for, let's say, so-called T1 cancers, you can T1A, which is just very thin cancers, the probability that's already gone into the regional lymph nodes is under 5%. So the T1A can warrant local excision. Once we get to T1B, it's a little bit deeper, those have a higher probability of being in the lymph node. So therefore, consideration for removal of the lymph nodes with it, which then necessitates, of course, not just a local excision, but a more formal, complete removal of that area with the lymph nodes. This is just a drawing of the EMR, the endoscopic mucosal resections I mentioned for very early T1A. Selected cases can be done by the gastroenterologist, and he still needs to achieve clear margins. And then, of course, we manage okay, what's the optimal extent of the gastric resection. I already talked about those as well. Subtotal gastrectomy. We talked about very early stage, we can consider local excision, depending on the location, either a subtotal or a total. What about the lymph nodes? We talked about it. So the removal of the lymph nodes are important for two reasons. One is it's important for staging, to determine the stage, but also we think it has some potential therapeutic benefit. That is, removal of the lymph nodes improves the outcomes in patients. So the lymph nodes, they're defined by where they are relative to the proximity or location near the stomach. The so-called D1 lymph nodes are the ones near the stomach, and the D2 lymph nodes are a little bit further away where the cancer can spread. And then, of course, the surrounding lymph node depends on the location. So the lymph nodes that a more proximal cancer can spread to versus the most distal. So so the type of lymphadenectomy, I'm sorry, these are called N1 nodes and N2 nodes. So the type of lymphadenectomy we recommend, should we do a D1 lymphadenectomy, just removal of the N1 nodes, versus the D2? The short answer is the D2 lymphadenectomy is generally standardly recommended to include in patients with where a gastrectomy is being performed. Parenthetically, let me just add one thing that I mentioned, that prognosis is very important to determine by removing these lymph nodes, and determining the extent of positive lymph nodes is a very important prognostic feature, and predicts the stage of the cancer. So the staging, as you know, is dependent on whether the nodes are positive or not, and how many lymph nodes are positive. Interestingly, as we move more forward to neoadjuvant therapy, that can confound the staging a little bit, because you can imagine if the lymph nodes are negative at the time of the gastrectomy in a patient that had neoadjuvant therapy, you really don't know whether those lymph nodes, and let's say the lymph nodes are negative, were those lymph nodes negative prior to chemotherapy? That is, the cancer was staged originally as a node negative cancer, or were the lymph nodes, or was there a lymph node or two, whatever, positive, that now is negative because of the chemotherapy? And we'll never know. Preoperative staging, often we didn't really talk about that. With endoscopic ultrasound can determine, and sometimes CT scan can determine, if the lymph nodes are enlarged or suspicious looking. That can give us a circumstantial evidence that that node was positive prior to the chemotherapy. But this is something just think about, as it can kind of confound the staging, the pathologic staging of the surgical specimen. Was it downstaged with the chemotherapy or radiation therapy or what? So what is the optimal extent of lymphadenectomy? As I mentioned, gastrectomy with curative intent should include a lymphadenectomy. The goal is to, I told you, to improve survival, and lymphadenectomy should include D1 lymph nodes as well as D2 lymph nodes. So that's the standard approach, is a D2 lymphadenectomy included with the gastrectomy, as we talked about the different types. Another surrogate metric of the D lymphadenectomy is just the total number of lymph nodes in the specimen. The NCCN and others have used 15 nodes as a guideline for trying to achieve at least 15 nodes in the pathologic specimen to really get a sense that it was an adequate lymphadenectomy. Just a word on the approach, laparoscopic versus open versus robotic now is being done. The short answer is there are some potential benefits in experienced hands. Like with others, it's a little bit difficult to show. I think it's fair to say that in experienced hands, that the oncologic different. There's no oncologic difference. There's one study showing that the survival of a minimally invasive versus open gastrectomy is no different. And I think it's pretty fair to say that in experienced hands with an experienced surgeon who's good at robotic or laparoscopic, that the lymphadenectomy is comparable, the margins, or everything is the technique. The oncologic operation is comparable. And in fact, there's and again, in experienced hands, the shorter length of stay, probably the complications are comparable, the pain may be less, the incisions are less, the wound complications may be less somewhat compared to depending on the size of it. But the reality is often may depend on the surgeon. So I would say it's a little bit dealer's choice, and I wouldn't be but it should be one approach like certain other operations. However, I do think that we're moving in this direction, and I think particularly, we're seeing with robotic assisted approaches and so forth, and sometimes even the lymphadenectomy can be more optimal, better visualization, and in selected opportunities to even have an improved operation with better visualization with a minimally invasive approach. Still not clear, not a huge difference. I personally don't think it makes a tremendous difference to one versus the other. Whatever the surgeon is most experienced at. If you have a surgeon that's very experienced with a laparoscopic or robotic approach, that's great, but either approach is fine. One thing just to bring up is surgery for, what about stage 4 disease? As I mentioned earlier, we typically don't there's no point in taking the stomach out for curative intent if the cancer is already spread. But in cases where it's symptomatic, where it's a bleeding cancer, then sometimes we may do a gastrectomy even when there's evidence of metastatic disease. In some cases like colon cancer with limited metastatic disease, like one metastasis in the liver, for example, for potential attempted cure, we'll do the colon removal and the metastasis, both. Remove the metastasis to try to cure the cancer. In gastric cancer, it's less so. If there's evidence of spread, then often it's not really likely that removing all the cancer is going to really cure the situation, typically. So we typically do the stomach surgery only for symptom relief, but without the goal. But people have explored in selective cases, is there a shot at maybe with effective chemotherapy, could we still try to eliminate the metastatic disease and maybe go after and do surgery? But that, I would say, trying to do surgery for metastatic disease is not standard of care. This is one protocol we're doing in the select cases. I mentioned to you that patients who have peritoneal disease found laparoscopically, that's already stage 4 disease, even if it's not seen on this CAT scan. And even if you do the cytology, that is, you go in with a scope before the chemo, no evidence of spread, you see the cancer in the stomach, and then we put in saline and fluid in there and aspirate it out, and then send that for cytology. If that cytology is positive, even though there's no visible metastatic disease, most consider that as also, let's say, very early stage 4 disease. And that generally precludes any role for surgery. However, at least some are exploring the possibility of maybe in that minimally metastatic disease, could there be a role for trying to do a gastrectomy? And so this is a protocol, this concept of HIPEC, which hyperthermic intraperitoneal perfusion chemotherapy, instilling chemotherapy, heated chemotherapy in the abdominal cavity for just this positive cytology. Is there a benefit? We use this therapy in appendiceal cancer and some forms of colon cancer. So this is an ongoing trial. This was a phase 2 trial at MD Anderson in Houston, looking at HIPEC in patients with positive cytology, as well as the gastrectomy. And we actually have this protocol open at Banner MD Anderson in Phoenix, looking at this Houston protocol, similar to the Houston protocol, to see whether this is really, I would say this is certainly not the standard approach, but in the positive cytology patient who gets chemotherapy, we typically don't, there's no role for do you do the laparoscopy again, still no metastatic disease, should you do the gastrectomy? think that's not the standard approach, but this is at least one protocol to see. Maybe we can do the gastrectomy combined with intraperitoneal chemotherapy, and there may be a signal that there may be some benefit in this setting, but quite still under investigation. Just briefly, palliative procedures for unresectable. So I told you that doing a gastrectomy in some cases for bleeding tumors or blockage or something like that. Also in cases where, let's say you have a distal cancer where there's blockage, there may be some approaches, or surgical approaches, where you don't remove the cancer, but you do. Remember that Bill Roth 2 picture I showed you, where you can connect the jejunum to the stomach, to the upstream, the stomach to the downstream, and you so-called bypass the blockage. So-called a palliative gastrojejunostomy is one palliative approach, can be done laparoscopically in order to allow the patient to eat. The other, in some cases, we can use, this is called a duodenal stent or a pyloric stent. You can see that just kind of props it open as a non-surgical palliative procedure for obstructing gastric cancer. And then other feeding tube and endoscopic ablation and other approaches can be sometimes done for unresectable. But we typically don't often do surgery except feeding tube, in this feeding tubes, or sometimes a bypass in patients with symptomatic. The other, sometimes you can use radiation also. I didn't talk a lot about radiation except in the proximal cancers. We don't use it as often in gastric cancer, but for palliative purposes of bleeding, sometimes obstructing tumor, you can use radiation beam therapy to improve that function. Just briefly, what are the complications or side effects of surgery? I won't spend a lot of time on this. Patients do pretty well. There can be, bleeding, leakage, so forth. Operative mortalities are fairly low in general, lower in good hands, high volume centers. Side effects of gastrectomy, I mentioned, nausea, heartburn, abdominal pain, diarrhea, particularly after eating. Bile reflux can be a problem, particularly with that Bill Roth 2, and I mentioned already a little bit about the dumping syndrome, not that common. Changes in diet will be needed often, not always, small, but more commonly small and more frequent meals. And one important point that often patients, I would say, are candidly over-fixated on, but not to worry that much. But as you know, that the stomach is not the area that absorbs oral B12, dietary B12, but it makes it what's called an intrinsic factor, a protein in the stomach lining that helps B12 be absorbed in the small intestine. And so if a total gastrectomy is done, patients can develop B12 insufficiency. And so B12 supplements, injections, or whatnot are as necessary in patients undergoing typically total gastrectomy. So in summary, on the surgical part, as I mentioned, okay, surgical resection does remain the principal modality, as I mentioned, for curative therapy. Curative therapy really necessitates surgical therapy used in those patients who have earlier stage cancer. We mentioned talked about the different options of extent of gastrectomy, the endoscopic, and also the different approaches, laparoscopic, robotic, or open. The lymphadenectomy part, of course, we talked about. That's an important component of the gastrectomy, and of course, achieving clear margins. When it's spread, then palliative surgery is done, and maybe selected cases we're exploring potential options for potentially curative intent approaches, even for more advanced disease. So let me pivot. I'm going to take the privilege here of the podium to pivot to a completely different topic, but I think it's really exciting, really interesting. And this is this circulating tumor DNA, ctDNA. What the heck is this? These are the cancers or cells release fragments of DNA. This is not circulating tumor cells. This is that cancer cells shed DNA in the bloodstream, in the plasma. And emerging technologies have defined the ability to detect these minute fragments of cancer mutated DNA in the bloodstream to be able to monitor the cancer with a blood test. Sometimes use the term liquid biopsy, and we'll talk about that. So these are small fragments of cell-free DNA that now, with the newer technologies, PCR type technologies, we can then detect minute amounts of DNA shed from even sometimes very low volume cancer. In fact, cell-free DNA is, your body constantly is shedding DNA in the bloodstream. You have a lot of cell-free DNA just from normal bone marrow, GI tract, skin. And so if you look at the plasma, you spin it down, the cells in the plasma, you can always pick up fragments of your normal DNA in the bloodstream. If you have abnormal DNA now with different techniques, you can detect it. And this was, in fact, first used, or maybe not first, but it's now commonly used instead of amniocentesis and others to detect fetal DNA. You can pick up fetal DNA in the pool of cell-free DNA to both to determine pregnancy, but also determine potential mutation in the fetal mutation. And it's used in transplant. You can see, you can monitor the foreign DNA in the bloodstream to look at tissue rejection. And of course, tumor DNA, the differences in the DNA, the mutations in the DNA from a cancer, they are different than the normal DNA. Small fragments can be detected in the blood, and that's the technique. And in fact, even early on, this is one study showing the landscape that these are patients with more advanced disease, but you can see that the percentage of the free DNA, that's the cancer, shed in the bloodstream, this is the percent, 1-2%. So it's a relatively small percentage of that same allele, if you will, or that same fragment can be mutated, and you can see it's still relatively common. This is in gastric cancer. We'll show you some data on colorectal cancer. That's the one that's ahead of the team, which had the most data, clinical data, to show the potential clinical benefit of ctDNA in the management of colorectal cancer. But gastric cancer is emerging. And really, there are different applications we'll briefly touch on. If you can pick up, you can actually, maybe it could be a screening test, or you can do it as a biopsy instead of to look at the molecular genetics of it, or you can look at it to monitor chemotherapy response going forward if it goes down with a dose of chemotherapy for advanced disease. And the area we'll touch on, which is most interesting, is this area here, which is MRD, minimal residual disease, after surgical removal. Did you get all the cancer out? Uh-oh, there's still some mutant DNA in the bloodstream of the cancer. That's not good. And so it's almost like picking it up early. So we'll talk about that briefly. So as I mentioned, diagnosis and so forth, but we'll focus on MRD, so-called minimal residual disease, for GI and cancers and gastric cancer. Mostly studied in colon cancer. You can see this is in, for example, you take stage 2 colon cancer, but you could say similar for stage 2 gastric cancer. Or where you do upfront surgery, we give chemo after. But many patients are cured, and we're giving chemo to patients in whom they're already cured from surgery, or that chemo won't have a benefit. So if you can identify which patients have higher risk, then you can then focus the adjuvant, the post-operative chemotherapy on those patients who have a higher risk, if you will, compared to those with no benefit, most of whom are cured with surgery, or even some that don't benefit. And so the idea, it's think about it as a, imaging. If you remove the cancer and now you detect the metastasis on imaging, then that's stage 4 disease. But if you think of the burden of cancer, lower and lower and lower until 0, then you have no cancer theoretically, but you never know if there's in the microscopic cell or not. So picking up detectable ctDNA is like picking it up earlier. And of course, you can see, I won't emphasize this, but this has been highly dependent on the technology, because if you have a technology that's poor at not sensitive at detecting ctDNA, it's going to be up here, where it's going to be almost, it may pick it up a little earlier than an imaging, but not much more. Where if you have a super sensitive test, you can pick it up almost, 1 in a million fragments, then, or 1 in 10,000 or whatever, then you can pick up MRD in a more sensitive fashion. I had the privilege of being one of the first studies, 2008, when I was at Johns Hopkins, to look at this. Excuse me, and this is an older technology called beaming, and in fact, it was shown to have to be able to pick up patients, to pick up minute fragments of circulating mutant DNA and looking at the dynamics after surgery and after chemotherapy. And now it's been further studies have gone on to show that after surgery, this is an interesting study, stage 2 colon cancer. Remember, stage 2 colon cancer, earlier stage cancer, typically we don't recommend chemotherapy in those patients. And but some could go on to recur. This study looked at all stage 2 colon cancer patients and found 14 of those patients, very few, 14 out of the 100 and whatever, 70 something, excuse me, had positive ctDNA. All of them went on to recur. And among those that are ctDNA negative, they had an outstanding prognosis. So one of the first signals to demonstrate that these patients could have been perhaps treated earlier than waiting until they recurred. And in fact, even in this study on these, they looked at compared to the low risk versus high risk, and you see even in patients who are clinically low risk colon cancer, even those 7 out of those 14 positive, even among those that had very low clinical features, wow, if you're positive, they all went on to recur. So very sensitive. I mean, hazard, I don't know if any of you are statistically inclined, I mean, hazard ratio of 28 is like unheard of in a clinical study. And so again, this is in colon cancer, positive, if you look at, so the predictive value, if you look at the positive predictive value of a positive ctDNA is 100%, negative predictive value 91% in this subgroup of patients. So very effective, clearly going to impact our ability and how we manage post-operative adjuvant therapy. It's emerged, starting a little bit in colon cancer, now more and more ways to, these are studies looking at predicting recurrence after earlier stage in others. So in breast cancer, similarly, positive ctDNA, stage 3 melanoma, lung cancer, same pattern. So really, it's starting to emerge as we develop this technology across the board in malignancies. And in gastric cancer, starting to show, here's this recent study of 2019, circulating tumor DNA sequence analysis for GE junction. They conclude that the characterized, this is not for MRD, this is in comparing to a tissue biopsy, that in fact that they found that the molecular heterogeneity rendered important prognostic and predictive information that was complementary to a tissue biopsy. So that's the other thing, is it comparable or different or better than tissue biopsy? You can imagine one advantage is that instead of sampling one part with a needle, you're getting a sense of all of the mutant DNA that's shed at least. And so, and of course it's less invasive, a blood test rather than a biopsy. Here's a study, longitudinal monitoring of ctDNA improves prognostication and relapse detection in GE junction gastroesophageal cancer, again, published in 2020. So again, emerging in gastroesophageal cancer, but a little bit behind some of the other malignancies. And this is just, if you look at just doing a lit search for 2020, for the first half of 2022 across the board, this is just a sampling in PubMed of how many studies across the board, colorectal cancer, and this is just colorectal. If you look at all diseases, it's just exploding. So it's really a lot going on in this space. Also, from an industry standpoint, a lot going on. These are just a sampling cut from the internet about all the companies currently that are now working in the ctDNA area: Foundation Medicine, Grail, Guardant, Haystack, others. So these are, a lot of these companies are currently, Natera is an area that's in the MDT, minimal residual disease area, with Signatera and so forth. So just a word on what, I won't go into a lot of the technology, but there are two forms. There's a so-called tumor agnostic, which is just where you use a panel of mutations, and it's and you can use potentially for diagnosis, or for, it's kind of doing a full panel of selected mutations. It's logistically easy, but it's more expensive and the sensitivity is lower, versus a tumor informed, where you take the patient's tumor, you analyze in the actual tumor, you analyze the mutations, and then you create a special blood test, a special ctDNA test for that patient's specific mutations. This technology has higher sensitivity. That is, you can detect a lower frequency of the mutation, potentially less expensive if you can do serial testing, but more complicated and requires molecular testing of the main tumor and then creating that special but lower cost one to do surveillance. So this may be the platform that's more often used for the MRD, for the serial monitoring, as opposed to this platform that can be used for the other areas. What do we know about ctDNA and adjuvant therapy? We know it persists after surgical. When it persists after surgical resection, it's bad. It basically means there's minimal detectable microscopic disease, cancer that's left behind. Most studies show any residual ctDNA present at the time after presumed attempted curative resection means that they're going to likely recur unless we can intervene with chemotherapy or something. A negative ctDNA, however, does not necessarily mean it's cured because of the level of sensitivity. It could be that it's better, but it still could mean, and it's also very dependent on the sensitivity of the actual test. We know from colon cancer that, and that even at ASCO this year, a study demonstrated that in colorectal cancer, that adjuvant therapy can decrease the likelihood of recurrence. So we think that giving chemotherapy to a ctDNA positive patient is not necessarily like metastatic disease, full-blown metastatic disease. It may not be a point of no return. The patients who would not recommend adjuvant therapy based on conventional risk factors, I showed you that stage 2 patient, positive ctDNA may warrant adjuvant therapy and maybe even escalated adjuvant. What is the future of ctDNA in the adjuvant piece, that is the chemotherapy postoperatively? Perhaps we can use sequential DNA to monitor and only give adjuvant when the ctDNA turns positive. So we could save a lot of patients who are cured with surgery, wait till they turn positive and then give the chemotherapy. This was the study in colon cancer just presented at ASCO this year. We still are not fully convinced that is that the same thing, but probably we think it's going to be similarly effective. And so this may be an approach to save all those patients with relatively earlier stage who are getting adjuvant therapy that don't need it. And we can, the other options, we can de-escalate it. If we can't at least forego chemotherapy, and those who are ctDNA negative, we can give kind of a chemo light approach perhaps. And then in patients who have ctDNA positive, even worse, we can use actually more aggressive than the standard chemotherapy. A lot of trials going on in this space, particularly in colorectal cancer. As I said, that's leading the way. This is just one example of patients. You can see this one activated, this one NRG study where patients are, you compare the standard observation in patients with stage 2 colon cancer, which is just to watch, versus ctDNA. If it's positive, chemo. If it's negative, you watch. So that's just one example. Others, again, in colon cancer, where you can say these are trials that are being examined, looked at, or in process. As I say, if you're ctDNA negative, you can randomize a patient to chemo or to mild chemo versus more aggressive chemo. That's one way to do it. Or you can do escalation if you have stage 3, where you normally give a more modest chemotherapy, FOLFOX or CAPOX. This is a study where you, if you're ctDNA positive, you randomize to the standard, which is to even a more aggressive chemotherapy, FOLFIRINOX. And what's really exciting about this approach is it could change the whole design of how we do trials, because not only we can design trials to see whether ctDNA can manage adjuvant therapy, but we can also use it as a readout. We can use clearance of DNA. Can you imagine if you're ctDNA positive and now you can determine if the drug is effective or not effective, not based on 3-year disease-free survival or 5-year overall survival, but clearance right away as a surrogate could really shorten the length of clinical trials across the board, as well as lowering the cost and exposing, instead of thousands of patients, to randomized clinical trials, we can limit the number of patients and get a result earlier. So I think the impact on clinical trials of this technology could be huge. Sorry, we're running a little bit late or close to time here, but the other applications, we're really focusing on this and adjuvant therapy. But let's touch briefly on some of these other things. As I mentioned, it's a very interesting concept, and it may be compared to a biopsy where you're sampling part of it. It may be that the shed DNA provides a more of a heterogeneous sampling of the molecular profiling. So we're just learning as to maybe the molecular profiling by liquid biopsy may be better. The other piece is that you can't be just biopsying tumors during therapy all the time, and even then you have heterogeneity within the biopsies. So by doing this temporal liquid biopsies during therapy, as I mentioned, both for minimal residual disease for surveillance, but also surveillance after surgery without therapy, monitoring the therapy even in patients with advanced disease. So the analogy I sometimes use is it's like a movie rather than a photograph. It's like a video rather than a photograph. You're getting a video of the biology of the cancer rather than a one-time shot or even having to biopsy at selected periods of time. So huge impact on even understanding biology of cancer, including gastric cancer. As I mentioned, the rapidity of here we start a new therapy or a new line of treatment, and we sometimes have to wait months for the tumor to shrink or a mark, something to change. Now we can see here within days, the ctDNA could drop as a measure of the efficacy of therapy of a new drug, for example. So faster. This is published by this is a study from Hopkins and a report from Scott Kopetz at MD Anderson. Other potential applications, in gastric cancer, as I mentioned, neoadjuvant therapy is really often the treatment of choice for earlier stage cancer. So how exciting this could be that rather than just give FLOT therapy routinely, how long do you give the FLOT therapy, and is that the best therapy? You can use ctDNA during the neoadjuvant to monitor the efficacy of the neoadjuvant therapy and either change the choice of treatment based on its efficacy or the duration. Some are even talking about continuing the neoadjuvant chemotherapy until you nadir out the ctDNA, and then you do the gastrectomy, for example. Again, these are all future investigational approaches, but just to give you a flavor of how this technology can impact how we manage cancer going forward. And better patient selection and timing. Maybe that patients don't need surgery if it goes away. So people are toying with this with a wait and watch approach. Caution there. Remember, I mentioned normal ctDNA does not mean that the cancer is gone. And then, of course, even in patients with early stage, instead of following with CAT scans or why not? We can just do a blood test, or if a patient has a positive ctDNA, we may not, if we don't treat, we can then do more aggressive surveillance versus those that are negative. So it could change even the cost of healthcare in our patients that we follow long-term for cancer. So to summarize this aspect about ctDNA emerging role in gastric cancer, well, I hope to show you that I think this technology is in the forefront of perhaps maybe hyperbole somewhat, but of revolutionizing cancer management. I think it has the potential to do that across the board. This tool also will have increasing implications for earlier stage, not just for advanced patients. May help transform how we do cancer clinical trials overall. And it's clearly going to show us how to even understand the biology of cancer, the tumor heterogeneity, what is minimal residual disease. We didn't talk about acquired resistance. Unlike colorectal cancer, there are limited clinical data currently impacting gastric cancer. You can see the huge opportunities here. So watch for studies coming out, maybe encourage, and who knows, I may even prompt Debbie's Dream Foundation to see if there may be opportunities for the foundation to fund research in this area. Very, very exciting area that's really helping to transform cancer care. So why don't I stop there? I'm sorry, I may have run a little long, a lot of information, but I hope this was helpful to all of you to really, and excite you a little bit on the future of where we're going in this difficult problem. Thank you very much for your time.
Thank you so much, for sharing with us today, Dr. Choti. The presentation was perfectly perfect. We received some questions during your presentation, so I'd like to ask a few of those in our remaining time. And it looks like we have some questions from Simone. Her first question is, can there be some confusion between lymphs being cancerous and inflammation due to immunotherapy? Her husband's oncologist believes that his lymphs are not cancer now by looking at the CAT scan, but he does say with certainty due to possible information from immunotherapy. He doesn't say it with certainty, I'm sorry. So is there some confusion between the lymphs being cancerous and inflammation due to immunotherapy?
And I think she means lymph nodes, right?
Yes, lymph
When you say lymph. Yeah, so first of all, immunotherapy, the use of immunotherapy specifically for gastric cancer, again, I'm not as familiar with the literature on how common that is. In selected cases, that there may be some indications for that. I think that lymph nodes in general are we can tell by examining them under the microscope with the pathologic specimen or a biopsy whether they're cancer cells or not. But sometimes they can be enlarged from inflammation, whether it's from immunotherapy and not necessarily, or just they can be enlarged in general. So an enlarged lymph node on a scan, for example, doesn't necessarily mean that it's positive. And of course, similar to the other way around, it's not uncommon that the lymph nodes are not enlarged, but have cancer cells in them. So and sometimes the pathologist can see, for example, residual ghosts, let's say, or mucousy material or something that's suggestive that there was cancer in the lymph nodes that's now gone. That's an indication of the effectiveness of therapy, whether it's immunotherapy or chemotherapy. So it's a good point that she brings up that always the lymph nodes that are enlarged can be related to other inflammatory conditions or other things.
Thank you. Our next question is, do oncologists ever restage if after chemo there's a reduction? So this person's husband has stage 4 gastric cancer, and there's been a lot of reduction. She wants to know, is there hope that if it reduces enough for after surgery that there will be a restaging?
We sometimes do restaging, as I mentioned. We talked a little bit about that. If there's already stage 4, of course, it depends on. It's good news, by the way. That's good. You like to see it reduce on therapy. That means that the chemotherapy, for example, is working. Even if, though, you go in and doing surgery, doesn't, as I mentioned, even if it's surgically removable, if there's already metastatic disease, there may be limited benefit to remove it, even if you can physically remove the cancer. so even if it shrinks, doesn't necessarily mean, okay, now you can take it out, because those other cells may still be there. Now, in selected cases, we may do that. And like if the cytology is positive and you give chemotherapy and you put a scope in again and it's still, there's no seedlings around, maybe the cytology now is negative. The second time, the cytology of the cells, even then, should you now do the gastrectomy, in selected cases, we may do that. It's not a standard approach. I mentioned what we're doing as a part of the trial is actually in those patients where we're doing the surgery and instilling chemotherapy, hot chemotherapy in the abdomen, which is also not, is an experimental approach. So not a standard, but I think every case needs to be individualized somewhat. There may be selected cases in which stage 4 patient cancer, where it's shrunk significantly, there may be a role for surgery, removal of all or part of the stomach, but not common.
Thank you. We had a general question. Someone said that if you've been diagnosed with stage 4 stomach cancer, is a total gastrectomy highly recommended? What would be your approach?
Say it again for stage 4.
Stage 4, is it highly recommended to just do a total gastrectomy, or like how do you go about determining that?
Well, no, as I mentioned, exactly the opposite. There's limited role at all for surgery at all for stage 4 when it's already spread. And I did mention that sometimes a palliative gastrectomy for symptomatic may sometimes do. total, as I also showed you that the morbidity, the complication rate is higher with a total and the function is worse with a total than a subtotal. So I think there's limited role for a total gastrectomy for stage 4 disease. That particularly, and even rarely do we do a subtotal, and less commonly do a total for stage 4. That's again when it's already spread. So I hope that answers your question.
Thank you. And one person says, what is the typical recovery process after a gastrectomy? Like how long does it take to fully recover?
Yeah, it's a good question. It's variable. Again, depends on the extent of the surgery, total, subtotal, that kind of thing. And it also depends on sometimes the approach, laparoscopic versus open. But typically, in my experience, let's say for a subtotal gastrectomy, you're in the hospital. Maybe it's an inpatient, of course. It's probably 4 days or so, something in the hospital, 3 to 5 days if everything goes well, if there's no complications. Sometimes a total gastrectomy, maybe a little bit longer. Some we may do a swallowing test, to make sure there's no leak with a total gastrectomy in some cases, where we typically don't, at least I don't in others. So I would say, in the hospital, maybe 3 to 4 days, 3 to 5 days, something like that. And then, back to work and other things, several weeks, sometimes a month, depending a little bit on the recovery and those kinds of things. So.
Well, thank you so much, Dr. Choti. Unfortunately, we are out of time for more questions today, but I'd like to thank you again for joining us, Dr. Choti, and sharing your expertise. And thank you to everyone who has attended today's webinar. Next slide, please. We'd like to thank our webinar sponsors. So we have our platinum sponsors, Amgen, Daiichi Sankyo, and Merck, our silver sponsor, Bristol Myers Squibb, and our bronze sponsor, Seagen, for making today's programming possible. And to view any of our recorded webinars or programs, please visit our lecture library on our website at debbiestream.org. And this concludes today's presentation. Thank you so much for tuning in.
Thank you. Bye-bye.